A very good morning and Jai Shri Krishna to all our viewers. This is Ketki Ashar on behalf of Team Drshtikon, extending a warm welcome to all of you to the 22nd webinar of Drshtikon Talks. We hope that you all are taking measures to stay safe and healthy. At Drshtikon Talks, we bring to you eminent Bharatiya speakers and experts to share their knowledge and valuable experiences with us. For this, we conduct a live webinar of 1 hour or a conversation with experts of different fields to widen our knowledge base and increase awareness. As we complete one whole year of Drshtikon Talks, we take this opportunity to thank you all for the continued patronage, and we hope to move ahead by imparting greater value to all those who attend our webinar. As we want the webinar to be conducted smoothly, we request you all to post your questions in the chat box. Our moderator for today, Mrs. Darshini Morparia, will take up the questions after the speaker completes the talk. Any unanswered questions will be answered by mail on the later date. Also requesting all of you to please switch off your mics and video. Our speaker for today is Dr. Sudha Ved. Requesting Maitri Bhatia to introduce our speaker to you. Over to you, Maitri.
Thank you, Ketki, for the introduction. Good morning and Jai Shri Krishna to one and all. I'm here today to introduce our honorary guest for the session, Dr. Sudha Ved. Marcus Tullius Cicero, a Roman scholar and orator, famously said, "In nothing do men more nearly approach the gods than in giving health to men." Nothing describes better the selfless service and devotion with which our doctors and physicians have been treating their patients over the years. Today, we have amongst us one such noble personality who has been benevolently treating her patients for over 4 decades. I'm pleased to introduce Dr. Sudha Ved, an eminent anesthesiologist with nearly 50 years of experience in delivering the highest standards of clinical care. Dr. Sudha has been associated with Georgetown University Hospital, an internationally acclaimed academic health and science center in Washington, D.C. since 1978. Dr. Sudha is an expert in the field of pediatric anesthesia, a niche specialty, and is known for compassionately treating her young patients. Born in Mombasa, Kenya, Dr. Sudha completed her M.B.B.S. from Lokmanya Tilak Medical College in Mumbai before moving to the US to specialize in the field of anesthesiology. She underwent extensive training at the Georgetown University Medical Center and obtained her residency and postgraduate fellowship. During her tenure at the university, apart from her role as a practicing specialist and department chief, Dr. Sudha has donned several hats and has risen through the ranks, undertaking a diverse set of roles, including chairing multiple committees on clinical protocols, anesthesia equipment and monitoring systems, JCI accreditation and regulatory affairs, quality assurance initiatives, and a range of other medical as well as administrative issues. She's an ardent researcher and academician as well, and has authored several research articles which have been published and presented at leading forums, including conferences of the American Society of Anesthesiologists, MARC, and International Assembly of Pediatric Anesthesia. Given her multiple years of experience in the field, she has also been instrumental in training of junior faculty members, medical and nursing students at the hospital on a wide range of subjects and was bestowed the Teacher of the Year Award in 2015. Dr. Sudha is here today to enlighten us on the nuances of 2 highly pertinent medical issues. Firstly, given her close interaction with patients over the years, her counsel to us to prepare ourselves before any upcoming surgery is truly invaluable. The guidance of such an expert can help ease our anxieties and apprehensions and make us aware of the precautions we can take to ensure a successful surgery. Secondly, it would be refreshing to gain a perspective from her on the ongoing COVID vaccination drive. No better than an expert to answer the FAQs buzzing in all our minds, be it the science behind the vaccine, their efficacy, or their dosage intervals. You're sure to get a better perspective on it at the end of this session. Dr. Sudha is currently based out of the US, and I would like to specially thank her for for being with us today despite the orders. Dr. Sudha, a warm welcome to you from the Drshtikon team. The stage is all yours.
Thank you.
You have to put on your video.
Yes, I am coming. I'm honored to be invited to give this presentation to the Drshtikon community. I especially want to thank Dhaval, who is my grandnephew, Darshini, Prashant, and the whole team and organizers of Drshtikon. Good morning and Jai Shri Krishna to all. Let me say that I'm devastated to hear all the news coming from India. I pray for all in India to have quick recovery from all the pain and suffering. First slide. I will be talking to you on two subjects, preparing for surgery and the state of COVID-19 vaccinations. Next. Let me say at the outset to all the youth that are listening is that anything you do and contribute in this world takes a lot of hard work and dedication. You must enjoy what you do. My library contains all kinds of anesthesia books, including pediatric anesthesia, my super specialty, 4 volumes of Gray's Anatomy, my medical school texts, 12 volumes of Mahabharata, and other books on history and literature. Gaining knowledge is my passion in all areas, not only in medicine. Next. I'm using this talk to mostly emphasize preventive medical care for yourself and your family. The need for this is mainly demonstrated when you come for surgery, minor or major, elective or emergency. Anesthesiologists are the gatekeepers of patients' well-being during surgery, besides providing unconsciousness and pain control during surgery. The goal is to identify and optimize medical conditions and educate patients and families. This will be emphasized with two distinct examples, an elective pediatric case and an urgent adult case. My pediatric case is a 4-year-old who presents for removal of tonsils and adenoids. He has 3 important medical conditions that will dictate my approach to anesthesia care. 1, he is obese. 2, he has obstructive sleep apnea. And 3, he has anemia. Obstructive sleep apnea is a sleep disordered breathing. The obstruction can happen in the nose from enlarged adenoid tissue or deviated septum, in the mouth with enlarged tonsils, or near the voice box from soft tissues. Other causes are from facial anatomy of the bones, small, lower or upper jaw, or any conditions that can affect muscle tone. The obstruction leads to constant oxygen desaturation. You all know what this means because of COVID, and may even lead to retention of carbon dioxide, like the classic Pickwickian character of Joe, the fat, red-faced boy who constantly sleeps in Charles Dickens' Pickwickian Papers of 1836. Pickwickian syndrome is actually named after this particular character in the Charles Dickens Papers. Next, the screening. For the screening test, the main reason is to optimize sensitivity, identify specific risks and specificity, and to avoid unnecessary testing, and to know what resources should be used to optimize the child's care. Next. Every patient before undergoing anesthesia requires a full medical, surgical, and previous anesthesia history, a list of medication, allergies, necessary lab and imaging evaluations, physical examination, and specialty consultations before coming up with an anesthesia plan. Next. All previous medical records are also examined. It is important for families to keep their own personal files and records since there are privacy regulations. It may be difficult to obtain previous hospital records. American Society of Anesthesia physical status is used to compare outcomes, the necessity of testing and specialty evaluations, and to maximize resources and to minimize unnecessary testing. Each patient is given an American Society of Anesthesia classification of 1 to 6, and E, which stands for emergency. ASA1 is healthy patients. ASA2 is patients with mild to moderate systemic disease, but can be medically well controlled, example of which is mild anemia, controlled high blood pressure, or controlled diabetes. ASA3 is severe disease process which limits activity, but it is not incapacitating. ASA4 is a severe incapacitating disease process that is a constant threat to life, examples of which would be recent myocardial infarction, recent strokes, or congestive heart failure, uncontrolled high blood pressure, uncontrolled diabetes. American Society of Anesthesia 5 classification is a moribund patient who comes to you with severe trauma, with a severe accident on the road, and is not expected to survive 24 hours with or without an operation. American Society of Anesthesia 6 is declared brain dead patient whose organs are being removed for donor purposes. For all purposes, patient is dead. The required elements next. The required elements makes that you have to formulate an anesthetic plan, risks and benefits are explained, and informed consent is also obtained from the patient. Pre-medication is also ordered. Next. For this child, it'll be important to know whether the anemia is because of poor nutrition and iron deficiency, which can be previously corrected at the pediatrician's office, or is it because of more serious condition? One example being genetic changes in hemoglobin molecules, such as sickle cell anemia or beta thalassemia, which may require hematologic consultations and blood transfusions prior to surgery. Because this child is obese and has obstructive sleep apnea, he may require chest X-ray and an electrocardiogram to rule out any strain and enlargement of his heart. A cough variant asthma may also provide a clue to strain on his heart. If present, he may need at least a week of continuous positive airway pressure mask to decrease the strain on his heart, improve his oxygenation, and fluid overload in his lungs from chronic airway obstruction. Next. Even though all this special evaluation is started at the surgeon's office in big hospitals, an anesthesia clinic uses the model of perioperative surgical home to collect all the necessary evaluations and surgical clearances based on guidelines written by the individual anesthesia societies, which are based on evidence, expert opinions, and outcome-based. The enhanced recovery after surgery, the ERAS, protocols are used in big hospitals for routine procedures such as colorectal surgery or joint replacement surgery. Rehabilitation, such as those with chronic lung problems, are asked to stop smoking. They are managed medically and with medications and deep breathing exercises. Those with weight reduction surgery are required to get leaner before surgery with intense nutrition regimen. And those for joint replacement are asked to start a month of physiotherapy in order to start walking the next day after surgery. There are intense protocols during surgery for fluid management and multimodal pain management starting before, during, and after surgery so that patients can be discharged from the hospital within 2 days and start ambulating or walking the same day of surgery. Anesthesiologists are usually in charge of these clinics, and based on the acuity of surgical procedures, immediate anesthesia consultation is provided. For elective surgery, we obtain all the information at least a month before surgery, and some lab tests are obtained within a week or the day before surgery. However, in reality, it's often driven by procedure-driven payments and insurance reimbursements rather than outcome-based payments, and unnecessary tests are repeated. Next. Besides enlarged tonsils and adenoids, there are many congenital conditions in children, such as cerebral palsy with low muscle tone, or Down syndrome with large tongue associated with airway obstruction and require special care and longer observations after tonsils and adenoid surgery. Next. Also less than 3 years of age and grade of severity of obstructive sleep apnea based on sleep studies and other comorbidities add to the possible outcomes with this surgery. Next. Children with obstructive sleep apnea have a higher risk of respiratory complications compared with healthy children requiring tonsils and adenoid removal. Next. We've already mentioned additional tests that may be needed for this child, which includes a polysomnography, which is a sleep test, and electrocardiogram and a chest X-ray. Next. One needs to prepare for admitting this child after surgery for prolonged observations since they are at higher risk for desaturation or pulmonary edema after surgery. Next. These are all the reasons for overnight admissions, which include less than 3 years of age, craniofacial abnormalities, if they live long distances and cannot come back to the hospital for emergency bleeding, if they have any postoperative problems, or if they are very, very obese. Next. This case example shows why it is so important to have preventive care and optimize your medical condition before surgery. Your outcome after surgery is dependent on that basic premise. We as anesthesiologists otherwise have to deal with all these medical issues in a crisis mode during emergency surgery, where the outcomes after surgery is not the best. This 72-year-old comes to surgery for hemiarthroplasty of the hip fracture, which is replacing the fractured ball and socket of the hip. She's found to be obese with uncontrolled high blood pressure and diabetes, and who has a stent in her heart placed 3 months ago with a history of congestive heart failure. She is very non-compliant with her medications. She ran out of her medications and did not have them refilled. The surgeon wants to operate within 24 hours and has requested a medical clearance for surgery. Next. Obviously, this surgery is urgent, and we only have 24 hours to get all her information of previous medications, is she on blood thinners, why she needed a heart stent placed, how her heart is currently working, and to optimize her uncontrolled hypertension, heart and kidney function, and diabetes. Next. We have a layman's test for what is her exercise tolerance test, whether she can climb steps without stairs or staircases without getting short of breath. Maybe a lesser complicated procedure of hip nailing or lesser duration may help improve her outcomes after surgery. Next. We have a revised cardiac risk index that we can use to predict her morbidity and mortality after surgery. She has a score of higher than 3. She has ischemic heart disease, congestive heart failure, and insulin treatment for diabetes. And therefore, she is a high risk for postoperative complications, 11%, based on these predictors. Next. We can put her data into a surgical risk calculator that is available online and try and figure out what her risk for myocardial infarction, stroke, bleeding, pneumonia, cardiac irregular heartbeats, heart failure, kidney failure, and death are after surgery. One can plug in all these patient data in the calculator and determine her risks and outcome after surgery. The goal is to improve her condition before the surgery. Next. She has and meets all the criteria for obtaining a recent electrocardiogram. We have to consider the age. Before, any patient that used to come to the hospital had a series of tests done, including an electrocardiogram. Nowadays, if the patient has minor surgery and has no symptoms, we do not ask for a cardiogram before surgery. If she has no cardiac disease or any cardiac arrhythmias, or if she has any valvular heart disease, including aortic valve disease, she needs to definitely have a cardiogram before surgery. And the time interval to obtain the cardiogram, if asymptomatic currently, is 1 to 3 months preoperatively. Next. Does she need a cardiology consultation? Yes, for sure. She has recent stent placed and needs to know how her heart is functioning. including a recent echocardiogram to know her current cardiac function. Anything needs to be done to optimize her physiologic condition. Yes, she needs correction of her high blood sugar levels with sliding scale insulin. She's a little fluid overloaded, needing water diuretics and adjustment of her blood pressure medications, and electrolyte and acid-base balance. She needs a blood transfusion prior to surgery and have blood products available during surgery since she has been on blood thinners. And she needs correction of her coagulation with fresh frozen plasma prior to surgery. Next. Even a short time to stop smoking will help oxygen carrying capacity along with incentive spirometry. Next. We like to continue most all medications for high blood pressure, oral anti-diabetic medications prior to surgery. Stop blood thinners 7 to 14 days before surgery, depending on the type of blood thinners. To conclude, what would you do in case you needed elective or emergency surgery in this case and not be in a crisis mode? Try and maintain a good lifestyle through all age groups, including good nutrition, sleep, get plenty of outdoors and sun, stay socially connected, and continue good exercise fitness programs. Have a life of purpose and with good mental fitness. This may include going to the gym, resistance training 3 times a week, aerobic exercises 3 times a week, even walking 30 minutes to an hour 5 times a week, or doing yoga. Doing preventive maintenance, doing preventive medicine, maintain your weight, keeping your cholesterol levels normal, high blood pressure and diabetes under good control, and can have a big impact on surgical outcomes, may even prevent you needing surgery in the first place. I have given you all the reasons to take care of your health on a continuing basis. It is not easy. It requires a lot of dedication and effort, all the more important after age 50. It is best to avoid going to the hospital in the first place. If you diligently need to have preventive maintenance for your car every 6 months to a year, your body also needs preventive tune-up every 6 months to a year. Visit your pediatrician and internal medicine doctor as directed by them, and more frequently as you get older. Next. So now this brings us up to the next hot topic of the state of COVID-19 vaccinations. Let me start by saying I'm not a virologist, epidemiologist, immunologist, or have any expertise in public health. Unfortunately, for many reasons, trust has been lost in good science, and doctors in particular. People forget how much progress has been made in medicine and technology, not only helping people live longer, but also in treating major infectious diseases such as cholera, flu, pneumonia, measles, polio, and smallpox in the past century. Maybe because of internet media, there is too much misinformation and not enough public knowledge. Let me start by saying, go get vaccinated. I got mine in December 2020. Probably the first group of people who were vaccinated in the US. Here in the US, vaccination has just been approved for children ages 12 to 15 as well. All vaccinations so far approved show variable efficacy rates of preventing COVID illness anywhere from 65% to 95%, and with good safety and minimal side effects. Even if these vaccines show low efficacy, they have been shown to prevent serious COVID illness, hospitalizations, and death if vaccinated. Next. I'm amazed to see how these vaccines, especially the new generation platforms, have been developed. There are high standards of manufacturing, testing, research and development, and quality controls in the processes, which used to take decades to develop. Now the production can be ramped up in 6 months because of biotechnological revolution. Over the last 10 years, since SARS, MERS, and Ebola emerged, new platforms and research have been conducted in animal trials and in severe biotechnological labs all over the world to prepare in advance for such an outbreak. This made it possible to do clinical trials and have vaccines developed at a breaknecking speed in just under a year. There are 3 approaches and platforms for developing the vaccine. The classical approach is at the bottom right, the conventional approach at the top right, and the next generation on the left side of the slide. Next. After SARS-CoV-2 was disseminated, the genetic information of this virus was disseminated all over the world from Wuhan, China in December 2019. The spike protein S code of the virus was of particular interest. The anesthesiologist is sleeping behind the curtain while giving anesthesia, while everything is automated. Almost there, we are almost there with the automation, except for the curtain. Maybe with the Google glasses, we may in the future be able to draw the curtain finally and be behind the screen. Next. This virus is a single strand of ribonucleic acid, which is enveloped by a protein membrane on which rests the spike protein like a corona or crown. This spike attaches to the ACE2 receptor and some other sites in the cells lining the airways, intestines, and the arteries, reproduces in the host cell and causes disease. Exposure to this protein should produce a protective immune response. Next. The classical approaches to produce vaccines are live attenuated or whole inactivated viruses. The viruses are multiplied in either eggs, which is a traditional approach, but recently they are only using cell cultures, and therefore no live animal is used to produce these viruses, to produce these vaccines. The virus undergoes chemical processes to either kill it or weaken it, yet maintaining its immunogenicity. Next. The spike is the target antigen. The conventional approach uses the whole S protein or protein subunit like virus-like particles and contains the antigen itself, whereas the next generation uses the genetic code, either the DNA or RNA, and person then makes the antigen protein. In the viral vector vaccines, part of another mild virus that produces very little illness in the body as part of its genetic material replaced by the S code of the COVID-19. Next. There is a difference between how the RNA and the DNA vaccine will work once it enters the cell. The RNA enters the cytoplasm, which is outside of the nucleus of the cell, and the DNA enters inside the nucleus. The cell machinery in the person then produces the spike protein, and the host immune cells recognize these proteins as foreign material and causes them to produce antibodies. The naked mRNA material has to be enveloped by lipid nanoparticles to gain entry into the cell. There is no live virus in the manufacturing process of these vaccines. It is unbelievable that they are just using the genetic codes that are produced and known, and they use proteins that have that particular RNA or DNA to make the vaccine. Next, the viral vector vaccines, they empty another virus of its genetic material and introduce sequence coding for the antigen. Next, the viral vector vaccines can be replication defective versus replication competent. Next, the replication defective viruses is a weakened or very attenuated, so will not cause any immune reaction to itself. The AstraZeneca uses the modified cell culture line, the HEK line, which was obtained initially from a chimpanzee adenovirus, whereas the Johnson & Johnson vaccine uses the human adenovirus 26. The replication competent uses the respiratory vesicular stomatitis virus and is produced by Merck AVI. It causes only mild flu-like illness, the virus itself, or no illness at all. Part of its RNA sequence is replaced by the RNA coding for the S protein. The virus replicates in the body. Merck developed Ebola, this vaccine, the same way. Next. From over 78 vaccines being produced and in clinical trials, there are many already approved in Russia, China, India, Europe, and the US. This slide shows how the human trials for vaccines are conducted. Only after phase 3 trials in hundreds and thousands of volunteers are the vaccines approved by the authorities. The Pfizer and the Moderna, AstraZeneca, all of the vaccines were given emergency use authorizations before complete data on side effects were produced. And there are still ongoing data still being tabulated to see how the antibodies, how long the antibodies will last and how long the vaccines will be effective. Next. This slide shows progress made with different technologies. As you can see, the whole inactivated viruses are the Sinovac and the Wuhan Institute, a biological product, Sinopharm. The protein subunit is a Novavax vaccine, which is used as a US Maryland biotech company and is currently starting phase 3 human trials. The adenovirus vectors, as I mentioned, was the AstraZeneca vaccine, the Bio vaccine with the Institute of Biotechnology, the Gamaleya Research Institute vaccine, which is the Sputnik 5 vaccine, the messenger RNA vaccines or the DNA vaccines. Messenger RNA vaccines produced are the Moderna NIH vaccine or the Pfizer BioNTech vaccine. Next. The AstraZeneca vaccine, which is the Covishield, is being produced by the Serum Institute of Pune. The results were published in Lancet March 21, 2021. This study showed 70% efficacy in 18 to 55 years age group with the first dose and slightly lower in the older age group, with antibody levels lasting at least 90 days. And the vaccine efficacy after second dose is higher if the interval dose is at 12 weeks rather than 6 weeks. So if anybody has questions about why we should wait 12 weeks to get a second dose of AstraZeneca vaccine, this particular publication gives you the answer of why it is probably better to receive the second dose at 12 weeks instead of 6 weeks. Next. This vaccine uses a classic approach of inactivated coronavirus or kill virus. It is given in 2 doses, 28 days apart, with an 81% interim efficacy. Next. In December 10, 2020, New England Journal of Medicine published the data on the Pfizer vaccine. The results of this vaccine showed protection 12 days after the first dose, 7 days after the second dose. The vaccine efficacy was 95%, 7 days after the second dose. The vaccine is given in 2 doses, 21 days apart. Next. The Moderna vaccine has an efficacy of 94.1%. 2 doses are given 28 days apart. Next. The Johnson & Johnson vaccine data were published April 16, 2021. The single dose was 66.3% effective 14 to 28 days after the administration. Next. All the approved vaccines in India are 100% effective in preventing death due to COVID and severe disease. 3 are currently available: Covaxin, Covishield, and the Russia Sputnik 5. They are soon going to authorize the use of 2 more vaccines, one which is produced in India and the other one is going to be produced by, which is a whole DNA vaccine, is also going to be approved shortly. Next, the Sputnik vaccine 5 and the Sputnik Light vaccine. The Sputnik 5 vaccine is a heterodose vaccine. That means there are 2 different types of doses of the vaccine. There are 2 viral vector vaccines are used for each dose. The 2 doses are given 21 days apart. The efficacy of Sputnik 5 is 91.6%. The second dose, the single dose, is an adenovirus 26, which is a viral vector. And the Sputnik Light vaccine is basically just the first dose of Sputnik 5, which is the adeno 26 viral vector, and is 79.4% effective. Next. This is a summary of the storage and doses required for all vaccines. Currently, only Johnson & Johnson is a single dose vaccine, but the biologic E is again 2-dose vaccine, but soon we will have maybe another Johnson & Johnson vaccine in India, which is collaborated with the Reddy's lab, I believe. So the other vaccines next, the other vaccines that are currently being tried out in India is the ZyCoV-D, which is a DNA vaccine by M.B.B.S. Biologic E vaccine, which is a Hyderabad US Dynavax Baylor College collaboration, is going to be called Corbevax. It's a recombinant subparticle protein unit vaccine, and it's undergoing phase 3 trials, and just recently given a boost by the Indian government to speed up production. There's a lot more availability of supplies that are needed from the US, and the Indian government has probably have good data to show with stage 1 and 2 trials, and have certainly boosted, and is expected to start producing by September 1 in India. They will have the 4th vaccine available in India. There is another vaccine produced by Biologic E, which is going to be collaboration with the Johnson & Johnson. There's going to be another vaccine by Pune, which is a HGCO19, produced in Genova, Seattle, a biotech company. There's nasal vaccine produced by Bharat Biotech, and the Serum Institute is producing its second vaccine in collaboration with Novavax. Next. The side effects include at the site of the injection and or the rest of the body. There are very rare side effects which include anaphylactic reactions or vaccine-induced thrombocytopenia, which is formation of blood clots, myocarditis, and death. These are very, very rare side effects indeed. And there's reasons why they're trying to find out why you would get blood clots, and they may have found why it causes blood clots, and they're in the process of changing the formulation of the vaccine to prevent this from happening. Everyone should get vaccinated. Next. The nasal vaccines, when available, may be able to prevent asymptomatic COVID. Pregnant ladies can be safely vaccinated. People with allergies to food, drug, latex, venom can safely take vaccines. People with serious anaphylaxis to previous COVID or non-COVID vaccines should avoid COVID vaccines. Next. Vaccinations 4 to 6 weeks after recovery. They may need only 1 dose, as robust neutralizing antibodies and strong T-cell responses have been found, even with a single dose. People who receive plasma therapy should wait at least 4 weeks before taking the vaccine. People with severe diseases should wait 4 to 10 weeks after recovery before taking the vaccine. Next. People with diabetes should go for vaccination after taking food, breakfast. Taper steroids to 7.5 milligrams per day for 6 weeks when taking this vaccine. No need to taper inhaled steroids for asthma. People with seasonal nasal allergies and bronchial asthma can be safely vaccinated. People on immunosuppressive drugs like methotrexate should stop the drug 2 weeks before and 2 weeks after the vaccine. Rituximab for non-Hodgkin's lymphoma, rheumatoid arthritis should be avoided for 4 weeks. Next. Those given monoclonal antibodies can be given vaccines safely. Those with bone marrow transplants, cell therapy should wait for vaccine until absolute neutrophil count returns to normal. Those for vaccine until absolute neutrophil count returns to normal. Those having surgery should take vaccines at least 2 weeks before surgery. For patients with autoimmune diseases like systemic lupus erythematosus, Sjogren's syndrome can take vaccination with extra caution. There is no data that exists currently to know for sure. The elderly people and people with dementia, paralysis, and neurologic conditions are encouraged to take the vaccine. Next. Stable chronic kidney disease, cardiac failure, liver failure should take the vaccine. The immune response may be poor. Patients who are immunocompromised, like patients with cancer or AIDS, they should preferably be given Covishield vaccine since it is a non-replicating viral vector vaccine. People can continue to take anticoagulants such as aspirin and clopidogrel before the vaccine. Next. Here are the original costs of the vaccine, but the costs of all the vaccines have been substantially reduced, and especially for the underdeveloped countries and through distribution by COVAX in conjunctions with WHO. Even the Pfizer and the Moderna vaccines have very, very reduced prices available to all the underdeveloped countries. The new vaccine, Biological E, is going to come in at, I think, 150 rupees, which is going to be probably one of the cheapest vaccine that will be available for everyone in India very soon. And for now, I'm going to pass the torch to Drshtikon, who is going to moderate the answers and questions that you have been probably busy writing down, and I'll be more than happy to answer any questions that you may have.
Thank you, Dr. Sudha Ved, for such a wonderful presentation. And I sincerely appreciate that your years of reading and research, your depth of understanding of the field, and your ability to present both the topics to us in such a simple and clear way has made this morning so interesting. Here, I must say that anesthesiologists are guardians of patient safety, uniquely educated and trained for the critical moments in healthcare. Since we are going through this pandemic, your comments are very timely, Sudha Ved, and I believe that we shall all benefit immediately from this session. There are many key takeaways from this session. Firstly, you have emphasized on personal health, healthcare, exercising, preventive medicine, so that we keep ourselves fit and do not fall into a situation of having difficulty while undergoing a surgery or facing any disorder. So firstly, people above 50, please do take care of your health, take care of your food, your diet, and be healthy. Coming to vaccinations, you've given us a insight into the different vaccines which are available all throughout the world, and of course, specifically to India, the 3 vaccines. And you have said the importance of vaccines. Vaccines do help us minimize the disorder or minimize, the levels of the virus affecting us, plus avoiding death. So please vaccinate yourself. These are the key takeaways from today's session. I will be proceeding to take some questions from the audience, Sudha Ved. The first question being, the first question being, during a surgery, first let us take up some questions on anesthesiology. During a surgery, does a patient under general anesthesia experience awareness of procedures? For example, talk happening in the operation theater or operation room. If so, should some care be taken for counseling the patient, since this may create some emotional disturbance?
That's a very good question, Drshtikon. What I can say here is the incidence of awareness under anesthesia is only 0.1 to 0.2%. But if you look at so many surgeries being performed annually all around the world, this incidence can lead to quite a few number of people who can be aware during surgery. If patient is high risk, especially the obstetric population and the cardiac population, where you may not be able to give a lot of anesthesia or adequate anesthesia, the risk of percentage of awareness goes up to anywhere between 0.4 to 1.2%. So what I say is, if you go back and take a look, there was certainly an example, and this became news when a patient undergoing colonoscopy had his phone on and was underneath the bed while everybody was talking and while he had sedation. Now, what happened here was patient was given sedation, but was told that he's going to be sleeping during the procedure. So these are two different things. I think anesthesiologists should, first of all, make sure patients are aware that if they're not able to provide very deep anesthesia, that awareness can occur. There are things that we can do to try and prevent awareness during surgery. We can give medications like Ambien or like Versed, midazolam, all of those help you not remember. You may be aware, but you will not remember it. You will have no recall of the awareness. You can give scopolamine, that is a very effective medication to prevent awareness. So awareness is possible to happen, but then what do you do about it? So I think, first of all, you have to make sure that you tell the patient the truth. You don't try to hide saying that you are at fault. You can certainly admit that awareness did happen, and then you can try and see if there's counseling that can be done for the patient to try and minimize the emotional side effects of awareness. So those are my key points about awareness.
Thank you,
And
Sudha Ved.
there are definitely ways to prevent awareness if you're not able to give adequate anesthesia, which include monitoring of the brain waves. We look at the end-tidal concentrations of the anesthetics that we give. There's a lot of things that we can use, movement of the patient that can be used indirectly to prevent awareness.
Thank you so much, Sudha Ved. Sudha Ved, I request you to please switch on your video. Your video is off, so we are unable to see you.
Okay, sure.
I will be taking the next question. This is again on anesthesiology. During a surgery, surgeon carries out the surgical work, but the anesthesiologist will continue to be responsible for the medical management of the patient. Can you please elaborate on this, the role of an anesthesiologist during the surgery?
I can say it in one word. We are the internists of the operating room. We are the ones who will take care of patient as a whole. Not only give anesthesia and prevent pain and suffering and produce unconsciousness, but our main role is to be making sure that patients' physiologic conditions are maintained as normal as possible, which includes, we try to keep the blood pressures, heart rates, any things that can happen during surgery. We try fluid management. We have to do some very, very detailed management of the patient if they're bleeding acutely. A lot of things can happen during surgery. And we are the gatekeepers and the carekeepers for the surgery. We are the internists. We have to make sure that we know what we are doing in a crisis situation. We have protocols that we use so that the patient is made safe. For unusual events or untoward events, which are rare, we have protocols that we perform right away so that everybody performs and the team approach is there to prevent disasters happening in the operating room.
I guess you're equipped enough to take decisions on the spot to save the life of the patient, which is very,
yes,
very
we
important.
don't have time to go to the library to look it up.
Right, right. I have one more question. What if someone has to go for an elective surgery after recovering from COVID? Since we are discussing about the COVID-19 viruses, what would be the effect of anesthesia on the patient? And is there a prescribed time gap to be given after recovery?
So again, here we come to the point of, is this elective surgery or emergency surgery? So, and what the patient's condition is after having recovered from COVID. In fact, I just had to cancel an elective surgery on an 18-month-old who came to the hospital, who had talked to the mom and had symptoms of coughing for last week. She had persistent drainage coming out of her nose, and we were going to try, and she was scheduled for ear tube surgery, but I knew this was going to be elective surgery. Her test came back positive. Right now, we are currently testing every patient that comes for surgery. We do a PCR test for every patient that comes to surgery. So this patient was positive, and so we decided to postpone the surgery. We have to wait till she's totally recovered from her symptoms and got a COVID negative test before we can perform her surgery. Going back to when we can safely do surgery, it all depends on the nature of surgery required, how emergent it is, whether it is possible to wait till all the symptoms have cleared up. Now, there is a certain thing called as long COVID, which affects the brain and the heart and things like that. And if that were to be the case, we would need to know and have detailed studies available for us to understand how the heart is functioning, how the lungs are functioning, how the brain is functioning, if there's any other side effects on the kidneys or the intestines or anything that we have to make sure that patient's in a stable condition to undergo surgery. And that would be my answer as far as how would we determine whether you can have surgery. So elective surgery, you wait until patient becomes relatively asymptomatic, and the anesthetic and the surgery should be no different than normal, or routine. But if patient requires emergent and critical surgery, which I've also carried out, I've given anesthesia to patients with active COVID who've had broken bones and need to be fixed, and I've had to give them anesthesia. But for those patients, again, if you do it, we take extreme precautions as anesthesiologists. We have to wear the full gear while we undergo, intubation and everything, and we change the gloves and the gowns and everything several times. The minute you leave the operating room or you're in the operating room touching anything, we keep on changing our gloves and gowns. We do that, but at the same time, if patient has respiratory or cardiac illness concurrently, then we have to manage it during surgery if the patient is sick. And that we are used to doing that on a regular basis regardless, but we try to avoid unnecessary surgery if we can.
Moving to the next question, we have a question from Upen Ashar. If one has taken first dose of vaccine, post which he has been infected with COVID, when should he take the second dose of vaccine? There are mixed opinions. Some say gap of 6 weeks, 8 weeks, or 12 weeks. What is the right gap according to you?
I would certainly go talk to your doctor is my answer to that one, because right now they said, after 4 to 6 weeks, you should take your second dose. But I'm not an expert on this subject, but I would certainly ask people who know more about this than I do.
Thank you so much. Question continuing in continuation. What if one cannot make it to the second dose, or what if one misses the second dose altogether?
So you're going to have continued immunity. We know that, at least for 90 days with the AstraZeneca vaccine, and probably longer than that. So as soon as you can, please go ahead and get your second dose of the vaccine. I know people are a little skeptical, especially less than 50 years of age, in taking the AstraZeneca vaccine because of the rare side effect of blood clotting. But depending on the countries, they've had different take on what to do with the second dose of the AstraZeneca vaccine. Like in Canada and Norway, I believe they are now doing ongoing studies in doing this second dose of the vaccine with another vaccine altogether and not the AstraZeneca one. Or we don't know the safety, efficacy of mixing the doses quite yet, but there is rigorous studies going on right now on mixing the different types of
vaccines. Yeah, there has been a case in India also recently in the last week of May in Uttar Pradesh, where about 20 people were administered 2 different vaccines, the first dose being Covishield and the second being Covaxin. So such instances also do happen.
I don't see particularly that there should be any problems, because these vaccines are given in such minute doses. And when they're given the effect is very local. It's only like in the arm. Only in the arm that you see that all this immune engine is starting to work. It's not like you give the shot in the arm and it's going to the rest of your body. It is not. It's only the immune response that starts here, then is helpful for the rest of the body in attacking any real illness. So I think people need to understand that what you're giving locally in the arm is not necessarily a big dose, or it's a big virus itself that's going to circulate all over your body and cause you illness. The vaccine should not cause you illness. It should prevent illness. I wanted to clarify that.
Thank you. We have a question from Sheetal, Jasrani and Dhaval. After taking both the doses of vaccines, will there be need to take booster doses in 6 months to 1 year?
Good question. There is a lot of variation and mutations happening with this virus. That's the first thing we know already. How effective are all the vaccines? Every vaccine will have a certain, shall we say, shelf life? Something like that. We don't know how long they're going to last. Coronavirus and its mutation is not like the influenza virus that mutates constantly. And we have to keep up with the vaccination. And only 60% efficacy for annual vaccination with the influenza virus vaccine. That is to start to know that. Coronaviruses is like common cold viruses. There are so many of them. They don't mutate that fast. Now, having said that, not all vaccines have the same immunity against the variants. They are different. Each vaccine will have to be studied into what its effectiveness is against all the variants, and depending on how much immunity you have, you may require a booster dose. May not be 6 months, but maybe every year, maybe every 2 years. We don't know the answers to that yet. We do know that Pfizer and Moderna are good and efficacious, almost 70 to 80% against all the variants. AstraZeneca less so with the South African variant, as far as I know. Lesser efficacy of like 30%. So I think you'll have to keep an eye out for every vaccine, and they're going to be the ones who will be recommending when the booster dose should be given. We should all be prepared for booster doses of these vaccines going down the line. But the good news is the messenger RNA vaccines. I just found out that they are now in the process of developing an AIDS vaccine with the mRNA technique, because right now all the other vaccines have found not to work for AIDS, malaria, all the other types of diseases, whereas the new technology, the new platforms may have larger success for treating cancer, for treating other illnesses, autoimmune diseases, AIDS. So I think this is a technological revolution. And like I said, we cannot ignore the scientific evolution that has have us live to 80 to 90 years of age, relatively in good condition. Our mortality has changed quite a bit. We're not dying in the 40s or 60s. We live to a long age now.
Because of the change in technology or the development in technology, while we are discussing about the mRNA, will future mRNA vaccine technology allow for one vaccine to provide protection for multiple diseases, thus decreasing the number of shots needed for protection against common vaccine preventable diseases? Would there be a possibility, or can we look forward to something like that?
I don't know about other viruses, but what they are saying is the S protein, the spike, or the other protein on the surface that is covering the mRNA, the virus itself, they are suggesting that they may be able to produce an mRNA vaccine that would be effective against all mutants soon. Now, will that be effective against all diseases? I doubt it. That is a very complicated question. No, I doubt it. That is probably not possible because mRNA is very, very specific against that particular protein, if you understand what I'm saying.
Yeah, I do.
You know, yeah.
So we take another question from Ashish Bhai. There are a lot of theories on the vaccine which are conspiracy driven, more so linked with 5G. What is your opinion?
You should not ignore the industry. The industry is out there to gain profits. And if you live in a capitalistic society like I do, that is foremost on your mind. Now, there may be instances where things may get better overall because economically the whole world is affected and the whole world needs to, we're all dependent on each other. So hopefully the capitalistic, can you say, itch will fade, and hopefully there'll be philanthropy and altruistic nature of this kind of illnesses and treatment for it, and hopefully it will be available to everyone. That's my take on that. But yes, it is a mean world, is what can I say. It is what it is.
Thank you. We take the next question from Nishant Asher. When, in your opinion, as a doctor, will the pandemic end? That is, I think, a question each one wants answers to.
Well, in reality, in the US, it has ended.
Okay.
Almost ended. We are there. There may be pockets of illness, but with the way the vaccination is going currently, 60% have received at least the first dose. And so also India, in actual numbers, the Indian vaccination is higher than the US, but you can look at it that way because the population of India is higher. So you don't look at the actual numbers, you have to look at how many vaccinations per population. And yeah, so for the US, 60% have received the first dose. And I think India is not too far behind. They're catching up very fast with all the other vaccines that are soon going to be available. Hopefully by the end of the year, India will be where US is.
Let's hope for that, Sudha Ved, because we are actually quite far. We've
You don't want the third wave.
Yeah. But the vaccination drive is really taken up, and I'm sure we'll be there soon.
Yeah, we don't want the third wave in India. We can prevent it. India is doing its best to try and avoid that. As far as I can tell, it needs to, but it's doing its best.
There's a question from Dr. Hira Lasher. How is your experience with hypnotherapy as an adjunct with medications? I repeat,
I have no experience with hypnotherapy. Unfortunately, I can tell you I have no experience. I know I had my colleagues that use that give have earphones or earbuds in the patient during surgery with soft music playing or distracting music playing while they're undergoing surgery or hypnotherapy, or they will do acupuncture on the wrist. They'll have a bracelet with a pressure point to try and see if they can decrease the pain response. So there are all those things that are currently probably being done, but in and of itself, we're not, at least I'm not a Chinese, and I would not know how to give patient heavy awake and not be in pain. I would not know how to do that.
There's a question from Ruchika Asher. My son, aged 1.5 years, has cleft palate and needs surgery. Is now a good time to do so?
So in United States, we usually have children undergo cleft lip surgery, just the lip, at age 3 months, even though they may be anemic at that time, which is physiologic anemia, which is okay. at age 9 months is where surgery is done on the cleft palate in the United States. So, and there's many reasons why we do it at that age. The main one being you're trying to affect speech, which is being developed at that particular point in time, and you don't want it to be affected if you do it later. Also, the effect on the sounds, and the child being younger may not have to go through trauma as much, So all of those factors, in the United States, the cleft palate surgery is done at 9 months usually. So 1.5 year, they should get the cleft palate repaired.
Go ahead with that is what you're advising.
Yes.
We have another question. When it comes to vaccines, most vaccines are approved for 18 years and above. Now, Pfizer vaccine has been approved by US and European Union for kids aged above 12 years. Is there any difference in the vaccine, or should the methodology being followed for administration differ for children or kids above 12?
It is the same adult dose that is given in adults. It is no different in age group 12 and 15. So my grandson, who is age 14, already has had his 2 doses of Pfizer vaccine. So there is no difference in the dosing of the Pfizer vaccine for children, and it's given in the same way. No difference.
No difference because of the different metabolism, or kids being more active. You think there is?
Usually the dosing in the younger age group, the 6 to 12 years age group, are being studied. In general, the younger age group, per weight, per body metabolic rate and all that, probably will require a little bit higher dose, as has been shown for all other vaccinations. But it's not the absolute same dose as for adults, but the teenage years, 12 to 15, have found to be the same dose as adults and found to have the same efficacy. So they have not changed the dose for the age group 12 to 16.
Thank you so much, Sudha. Maybe last couple of more questions, because it's quite late in the night for you.
That's okay. I'm quite awake. Thank you.
Okay. One question was, could you throw more light on how nasal vaccines work?
How nasal vaccines?
Nasal vaccines. You mentioned nasal vaccines. The other vaccines are injected on the arm.
Yeah, so the nasal vaccines hopefully are going to produce immunity locally in the nose and prevent entry of the virus into the rest of the body, since it is aerosolized entry for the virus. So if you can stop having the nose is a very, very immune organ, just like the intestine is a very, very immune organ. When I'm doing intestinal transplants, I know what they're talking about. It's a very, very immune organ. It's very, very hard to suppress the immunity, with these things. So if you can give the vaccine locally and cause local immune response, hopefully there'll be less illness. And hopefully they can produce that for the influenza virus and common cold virus also. That would be a very, very good thing, because everybody gets cold. It takes you out of circulation for a day or two.
Yeah, I hope something like that comes up, because
yeah,
it will help one and all.
That's right.
Thank you so much, Sudha Ben, for sharing your valuable time with us and patiently responding to all our queries. With this, we come to an end of today's insightful session. Thank you so much for being awake for us and giving us this knowledge.
I'm more than honored. Thank you.
For the participants, as Team Drshtikon is celebrating completion of 1 year of conducting these webinars, on behalf of the team, I take this opportunity to place on record our gratitude and a big thank you to all our viewers and participants, both on Zoom and YouTube, to all our speakers, to all our volunteers who've come forward to introduce the sessions and the speakers, to people who've helped us identify and also who have helped us, introduced the speakers to us, or who've helped in promoting the sessions and suggested speakers to us. And last but not the least, all our well-wishers, a very big thank you to all of you. All of you, in your own special way, have helped us make the program interesting, make it a value proposition, and helped us reach out to different corners of the world. A very big thank you to one and all. In India, 1st of July is observed as Doctors' Day. It is celebrated to emphasize the value that doctors hold in our lives, and this day is meant to pay them respect for their selfless service. While wishing Dr. Sudha Ved a happy Doctors' Day in advance, we are very glad to announce that our speaker for the next session, that is on 4th July, is also a doctor, Dr. Nipaj Asher, a dentist, who will speak on dentophobia. So please join us on 4th of July for the session. On behalf of Team Drshtikon, Ketki Asher, Maitri Bhatia, and me, Darshni Morparya, signing off for today. Have a great weekend. Stay safe, stay healthy.